She got an internship. You know, she's going to school. She got her promotion at her job. And then she got an internship. So
Okay.
the one that kind of fell by the wayside.
Yeah. There's a slide in here.
Hello. Check one. Check 1, 2, 3, 4. Testing the microphone. Test of the microphone. Check. Talking to the microphone early in the morning. Walking around. Sounding good.
Good morning, and welcome to the Colorado Health Access Survey 2017 Big Reveal and Launch. My name is Michelle Leek, and I'm the president of the Colorado Health Institute, and I'm delighted that you have all chosen to join me and the team from CHI here today to learn about the results of the Colorado Health Access Survey. I know there's a lot of places that you can spend your time, including listening to Trump at the United Nations, so I appreciate you taking the time to be here with me instead. It takes a village to put on it's not even a presentation, it's an entire palooza of events happening around the Colorado Health Access. And I want to start out with a shout out to my colleagues at the Colorado Health Institute. I come on at the end to present the findings, but there's a lot of work that happens backstage. I want to make a shout out to 4 of my colleagues in particular, Teresa, Jeff, Brian, and Deb. You know who you are, and thank you for your work on this project. I'd like to also acknowledge the generous support of the Colorado Trust. They have been a long-standing partner and generous financial supporter of the Colorado Health Access. This is the 5th year that we have been able to bring to you results about the survey that we do of 10,000 households. This represents a decade's worth of time. So this is one place where we can really see the progress that we're making in terms of our state's health policy goals. I'd also like to thank 2 new partners this year who came on board and sort of bought real estate on the survey. They've added some questions around access and end-of-life care issues. So a special shout out to the Department of Healthcare Policy and Financing and the Colorado Health Foundation. I want to acknowledge a few key important state legislators who have joined us here today. Representative Susan Lontine, Representative Dan Pabon, Representative Daphna Michelson-Janay, Senator Jim Smallwood, Senator Irene Aguilar, Representative Alec Garnett, and Representative Lang Sias. I thank you for being here. Thank you for joining us. You have first turn in the Q&A session, and so I'm just giving you an opportunity to know that in advance. But I think it's important that we hear from our legislators in the reaction to the results that we have. It's totally elective. You don't have to say anything if you don't want to, but I'm putting you on notice. All right, so do we have slides? That's always helpful in a presentation. Did my computer go to sleep? Becca's here. So the Colorado Health Institute is based on a really simple premise. We've been around for 15 years, and that premise hasn't changed very much. We believe that better health policy leads to a healthier Colorado. It leads to a healthier us. And we believe further that health policy is best when it's informed by disciplined research and keen insight and rigorous analysis. And that's what we do at CHI. Each and every day, that's what gets us up in the morning. That's what we do for a living, and it's our purpose and mission to bring that information and analysis to the health policy decisions that we make. And it's in this context that we bring to you the Colorado Health Access Survey. This is how we begin to understand the changes that all of us in this room are working on in one way, shape, or form or another. This year, we're able to see what's happened in the last 2 years, but because we've trended this over a decade, we can see how we've done over a longer period of time. It's particularly important to think about how all the work that we do as a policy community impacts the health of our fellow Coloradans, our neighbors and friends in Denver and throughout the state. we want to know things like, do Coloradans, how are we getting health insurance? Where are there barriers and challenges to access? And the CHAS allows us to do just that. As a little reminder, we do this survey biennially, which is a word that I can't even pronounce, and it's a fancy word meaning we do it every other year. We survey over 10,000 households, and we do that because we want a representative sample. We want to make sure that we can understand things by race and ethnicity, by income, by education levels, by the kinds of insurance you have, and so that we have a more robust and comprehensive idea about what's happening in terms of health insurance and access within the state. And a couple of details, because I did a few rounds this morning, and I know that a few wonky people out in the audience, I won't say your names out loud. It's 10,000 people, it's representative. It's a robust enough sample that it's representative in a whole lot of ways. It was fielded between February and May of 2017. We went into the field the day after open enrollment closed. That's an important anecdote. And yes, we fielded the survey in both English and Spanish, and we contacted people on cell phones and landlines. This is the first year that we sampled more people by cell than by landlines. That's reflective of the changing landscape. So we want to figure out, the CHAS is going to let us know, it's going to allow us to pause as a community to understand where we are. So, but the first thing you need to understand about where we are is that we are all over the place within the next 48 hours. The team that is 23 people strong at the Colorado Health Institute is taking these results to 15 different locations across the state. We will be in places like Lamar and Sterling and Cortez and Craig and all points in between. We're doing this for a variety of reasons, but mostly it's because policy occurs in a lot of different places. Policy occurs at the local level and at the state and national level, but policy really makes a difference on the ground and where people live. It also means that if you love what you heard this morning, you can come with me later this afternoon or tomorrow morning. So if you're interested, we have carpools and vans leaving here to move out. Just let us know about that. The CHAS, what I'm going to share with you today are 10 brief storylines that we think are really important in the findings of the CHAS. But this is our first go at really looking at this data. We came out of the field in May of 2017, and we've had the data in-house in a cleaned version for about a month. And so we are, at the first glances, looking at this. Over the next 18 or 24 months, we'll be doing a lot of in-depth, detailed work around these findings. But I have an ask of you as I move through these 10 findings today. I need your help, and I'd like your help in 3 different ways, if you're willing and able. First, as we move through these data, where should we dive deeper? What's of interest to you? What do we need to probe to understand a little bit more? Second, what policies have contributed to the changes that we see? I'm asking you to look internally at the work that you and your organization is doing, or have been doing. Where is that manifesting itself in these results? What's the story that we can tell? What's the frame that we can use in order to understand this better? So tie your experience to these findings. That would be helpful. And also, what do our findings suggest for further policy ideas? What ideas can we generate from this research that will help our legislators, our representatives and senators either introduce new legislation, think about different ways of working with Medicaid, so on and so forth? I think that these are important questions. So keep these in mind as you go through. My trusty colleague, Deb, is taking notes, and we're making a recording of this from the 15 different locations, so that would be helpful. So are you guys willing to do that? Sure. Okay. It's morning, but it's still, come on. Hello. All right. So a lot has happened since 2015. I don't need to tell you that, and that's probably the greatest understatement I will make in this presentation. But we've seen a lot of things here in Colorado. We've seen a lot of uncertainty and spiraling, escalating costs in the health insurance premium market. We've seen a spike in prescription drug costs. We've seen uncertainty about which insurance carriers will be in which markets. And of course, on November 8th, we had a surprise results of an election and the Trump administration. So remember that when we fielded the survey, repeal and replace was a thing in Washington. It continues to be a thing even this week as the Senate has their last attempt to carry forth with repeal and replace. But this is really in our psyche. There's a high news visibility, high awareness of repeal and replace arguments. And these are important things to keep in mind. So with that, I will move right into the question that everybody asks, the one that garners the most headlines, and that is, what is our uninsurance rate in 2017? And I think that we should take a moment to congratulate ourselves for holding the historic gains that we made right at the onset of implementation of the Affordable Care Act. We are holding our own. We have almost 94% of us continue to have health insurance. And given those changes that we've seen in the marketplace, we think this is newsworthy and noteworthy. So this is what the uninsurance rate looked like over the lifetime of the Chaz, right? We started in 2009 at 13.5%. We peaked somewhere near 16%. And then we've been on this steady decline since the implementation and the passage of the Affordable Care Act, and we're now at 6.5%. So this is, from a statistical standpoint, essentially the same or unchanged. And even though it looks like, you say 6.7 and 6.5, isn't that a trend in the right direction? It is, but it's a trend that we can explain by either noise or luck or randomness within the data. So from a very conservative and disciplined approach, we would say that this is relative, we're maintaining the same level rather than seeing a major change or reduction in the uninsured rate. I have to tell you that this surprised us a little bit at CHI, and we have an office bet to prove it. But we also had a bigger bet out there, and so many of you know in this room, and submitted a response to a contest that we ran. And the idea is, submit what your guess is of the uninsured rate. If you win an iPad. That doesn't sound so bad, does it? So a third of you who sent in responses to that contest estimated that we would go up. That 6.7 would be the lowest that we ever had. 2/3 of you thought we would go down. Some of you thought it would go drastically down. But only one of you got it exactly right. And that person is Chris Clean from the Center for Health Progress. So a shout out to Chris. Now, some of you who are really, really attentive listeners and have good memories will remember that someone from the Center for Health Progress won this 2 years ago, and he's actually sitting right next to the person who won it 2 years ago, Sarah McAfee. The fix is not in. This is not a broken system. They are either very lucky or very, very smart. And so in 2019, I would suggest that you consult with the Center for Health Progress before submitting your guess. But congratulations, Chris. Tim, the guy in the back right there, has all the details about how you get the iPad. It's not me. Do not come to me for that. So let's dive in a little bit deeper to the findings here. We're seeing this improvement, but we don't see it sort of uniformly. And so this is looking at for those of you who want to follow along, I am going to be on page 12 of the chart book that you have in front of you. If you're the kind of person who likes to sing from the hymnal. You can follow along. Page 12 is where I'm at to see the data up close and personal, or if you need bifocals like myself, it always helps to have it a little bit closer. So I mentioned earlier in our statewide release that we are headed to 15 towns and included our Cortez, Lamar, Sterling, and Craig. And for this presentation, I want you to keep your eyes on those four corners, not the four corners that people go and visit in the tourist locations, but the four corners of our rectilinear state. Because this is going to share with you, this is an easy and visible way of understanding that health reform, health policy implications don't hit us all uniformly. So you can tell from this, the darker the blue, the more likely it is that you don't have insurance. And you can see from those four corners that it looks very different than the central parts of the state, right? This is where we have more people in our rural and frontiers areas that don't have health insurance than those who have it in the urban or I-25 corridor. So I think that's an important point as we move forward. I'm going to turn now to, I think it's actually on the same page, page 8 actually. I'm going to look at how people get their health insurance. And then how as Coloradans we are getting health insurance is changing quite a bit as well. So the red bar here, the first thing I want to share with you, I want to share with you three things on the slide. The red bar indicates uninsurance. And so we've seen this, I showed this to you in a different visual format 2 slides back. But we've gone from a high of 16 down to a low of 6.5% in terms of our uninsured rate. What's also interesting this year is that this year, for the first time since we've started the CHAS, fewer than half of us are getting our health insurance through our employer. I think that this is a tipping point, if you will, in terms of how we think about the insurance market. And so this is the first year we're at 49.5% of Coloradans, and so it's still how most of us get our health insurance, but you see that from the 2009, sort of during the economic recovery from the recession, we were nearly at 60%. Some of that can be attributed to us aging. We're all getting older, which means we move into Medicare, and you'll see that that ticks up a couple of percentage points. But I also think that it speaks to sort of more fundamental issues about people not opting for coverage or employers not offering coverage in this market. And thirdly, I just want to point out Medicaid. This was a surprising finding to us. Medicaid held, it's still at 20% on the CHAS survey of Coloradans. So this indicates that 1 in 5 of us is covered through Medicaid. We were surprised. We thought that number would be higher, and the administrative roles at Medicaid indicate that it actually is higher. It's about 24-25%. I want to point out that I think that there are a couple of issues going on here, some of which I will return to later. First of all, our population is growing really, really quickly. Over the last 2 years, 200,000 more people moved to Colorado. So we have, that's about 100,000 a year, or just under 5,000 people a month moving into the state. We think that when you have a snapshot in time, you may not be capturing everyone, so that may factor into why that Medicaid is undercounted. Second of all, we know in these kinds of surveys, we did a number of analysis, lots of research around this, Medicaid tends to be undercounted in a self-reported survey, and we've documented that in the literature. And thirdly, what I think is important for us to think about as a policy community is that we've noted for the first time a lot of confusion about the kind of plan that people have, and I will return to that, but that's also factoring in to this Medicaid undercount. So story number 2, if you drove in and were listening to Colorado Public Radio, they beat me to the punch on this one. We are 5 million strong. So another way to not think about percentages, but think about the number of people who have health insurance within the state. We topped 5 million. For those of you who are historians and trivia buffs, you will know that we didn't even have 5 million people in this state 7 years ago, right? It was only in 2009, 2010 that we topped 5 million. And so what I learned from this is that even though 100,000 people a year are moving into the state of Colorado, we are doing a pretty effective job of getting them into insurance right away, getting them enrolled in insurance. That still leaves, I want to say here, 350,000 people who still don't have insurance. And that's I think a challenge for this community is to figure out how to go get those guys insured. Last way to think about this is the Affordable Care Act primarily set out to do one thing, and that one thing was to get people insured. Sure, there's lots of other things about how we're going to change payment and change care delivery, but I would argue that the primary focus of the Affordable Care Act was to get more people insured. And so one of the things that you can do with a trendable longitudinal survey like this is that you can look at sort of pre and post, right? If you're in health policy or your health services research, you love stuff like this, right? Because you can look at things before and you can look at things after. You can also do that in places like Cosmopolitan and Vanity Fair. They have different subject matter, but still, that's the idea behind it, right? And so we have 600,000 people who got health insurance because in some way, shape, or form from the Affordable Care Act. So that's sort of the delta. 600,000 people is really hard to sort of get your head around. Like, how many people is that actually? If you take the population of Colorado Springs and you add it to the population of Fort Collins, that's when you're talking about 600,000 people. This is not an insignificant number of people who gained health insurance through the Affordable Care Act, the choices that we made, and the work of many of you in this room. So storyline number 4, if you are part of a vulnerable population, you are still more vulnerable than others. However, the story is changing, and it's changing and improving in the right direction. The disparities and inequities that we see in terms of coverage and access to care are actually shrinking. They're still there, but that gap is narrowing. And I want to share with you a couple of examples of that. First of all, let's look at income, insurance by income. Oh, and I can tell you what page this is. Hold on, because that's maybe challenging for some. So this will be on page 14 of your chart book. And I'd like you to take a look at this chart in a couple of different ways. First of all, let's look at an individual cluster on the chart. And so it's 2009 to 2017, and these are the income groups going across the x-axis. Each cluster represents the rate of uninsurance for each income category over the last 8 years. And in all cases, we see a drastic improvement from the years 2009 and 2011, so the gray and yellow, we drop right down with the blue and the red. And so in every single income category, that tends to be the case. So look at, if you will, the 100 to 200% of FPL. We started here at nearly 30% of people back in 2013 who were not insured, and that's now down under 10%. And I would call that pretty significant improvement in that rate. But also take a look at it from a second perspective and look at the red bars in comparison to each other across these different income levels. And this is where we see some disparities emerge. It's still the case that lower income brackets are more likely to be uninsured than the more affluent groups, but the rates are similar for everyone below 300%. So I would suggest to you that that gap is really narrowing. The one place where we see something funny happen is in this 200 to 300% of FPL, and so there's still people who are getting subsidies, but not quite as much as perhaps is needed, particularly up in the ski resort communities. But I think that We think that some of this has to do with Medicaid churn and changes in the economy where people start making enough money to disqualify themselves from Medicaid. But I think something else is happening here. I think that let me change this. I want to turn to looking at not just income but age. And when we look at age, which is still on page 19, I'm sorry, let me see what page it's on. Oh, Deb, I don't have, page 16. So when we begin to look at things by age, we see different kinds of stories emerging. If you're a kid or if you're a senior, things are looking awesome for you. Kids have a lowest uninsured rate that we've seen. It's hovering at 3%, which is statistically the same as what it was in 2015. And there's virtually no seniors who don't have some kind of coverage. But look at the group that's 40 to 54 years old. And we see an increase in their uninsured rate between 2015 and 2017. And I thought we were thinking about this. Of course, we don't know exactly what's going on with that age group. But I'd like to introduce you to some really, really good family friends. They're the Link family, and they're pictured here. The Links live in Basalt, Colorado, and many of you know that before I worked at CHI, I too lived in Basalt, Colorado. They are friends. Dylan and my son Jack are 3 days apart in age. They met in preschool, and at the age of 2.5 years old, they decided that they were going to dig a hole to China. You know, it's that kind of relationship. We have been friends and have stayed connected over the years and over time. And this year, we both sent our sons off to college. And so we went, and it's all exciting, right? You move into your dorm room. This is the Links with Dylan in his dorm. They're moving him in. You have to go to Target and Bed Bath & Beyond and all sorts of places to make that happen. But the Links are not insured through their employer. The Links own their own property management company. The Links buy either on the exchange or through an individual broker, depending on the year. The Links have a $5,000 deductible plan. They pay $2,500 a month in health insurance. And when you're making that decision between paying for your kids' college tuition or paying that bill for your health insurance premium, that's a lot of pressure. And even though I have been in healthcare for 20 plus years now, I couldn't tell you today that if I had to make that choice that I wouldn't sign that check to Colorado State University first, right? I mean, it's that kind of hardship. It's that kind of financial pressure that people are really feeling. And I can't say this is exactly the cause of why we're seeing that on the Chaz, but this is the story that it reminded me of when we were sort of discerning what those numbers are. So goodbye, Dylan. Have fun. We are making some really notable steps in the right direction, and I want to point out to you how we're doing in terms of ensuring one of the most vulnerable populations among us, and a population that has had high uninsured rates for a long time, and that's the Hispanic population. In 2011, they were up at 26.5% of the people of Hispanic origin reported on the survey that they didn't have health insurance. Look at how that number has dropped to 10.4%. So if you are involved in outreach and enrollment, remember those questions I asked you about how you see yourself in this work? Where are you working? I want to hear from you at the end of these remarks. What's going on, and how do we get that down to 5.4% so it's reflective of the community and the state overall? So putting some thoughts in your head here. Second, the story number 6 is this idea of stabilizing the health system. For those of you who were around a few years ago during the implementation of the Affordable Care Act, and we were devising our systems and thinking about the policies and strategies to insure this many people, we used a few different words back then. Does anybody remember the term bolus? Does anybody remember pent-up demand? Remember how worried we were about pent-up demand? Do you remember the idea of the welcome mat effect and how this was going to, the idea was there'd be so many people coming into the healthcare system that the healthcare system would break. It wouldn't be able to take care of everyone in that system. And thanks to the Department of Healthcare Policy and Financing, we asked some questions specifically about that this year, and we have really good news to report. And that news is that people are by and large getting the care that they need, and pretty much by and large when they need that care. So we asked people about wait times across Colorado. So this is how long do you have to wait to get to a general practitioner. This is the first slide that you're looking at. You can find this on page 23 of the chart pack. And so you can see a couple of interesting things on here. The darker the orange, the less true that is about you. You have to wait longer for those primary care general practice visits. And you see sort of an interesting sort of swath across the sort of southern part of the state as well. But the light yellow areas indicate that we're doing a pretty good job. It's between a day and 2 days to get the kind of care that you think you need. The picture changes a little bit when we look at specialty care, right? And so the darker the orange, you have to wait longer. On this slide here, the average is 2.5 days to get to a general practitioner. Here, it's 9.4 days to get to a specialist. Still not so bad if you're thinking about that you have to maybe go to a primary care doctor, or you have to get a referral, you have to wait for the paperwork to come through. 9.5 days is the median on the survey in terms of how long it takes to get to a specialist. The story changes, of course, when you look at our four corners. And if you're here today and you do work thinking about specialty care referral, this is the challenge that we have in front of us, right? So we have lots of things going on. We're involved in telehealth and e-consults and Project Echo and a specialty referral stewardship committee and all sorts of things that are going on in order to enable specialist visits to reach people in who are outside of the urban corridor. We've seen legislative activity allowing for telemedicine and telehealth visits. We've seen Medicare reimbursement change in terms of improving access to specialty care through reimbursement strategies. We are actively working on this issue. Again, where do you find yourselves? Where is your work in this? Question number 2. And question number 3, what does this imply for policy decisions, policy suggestions moving forward? I'd like to come back to that. Story number 7, the Affordable Care Act is not affordable yet. If you're sitting at this table up here, I see the legislators have taken the front row seat, thank you very much, we are grappling with this issue each and every day. We're doing that in the Capitol, we're doing that in our offices, we're doing that in policy committees, we're doing that in philanthropy. We are worried about the idea that the Affordable Care Act is not quite affordable. And of course, we see that in 2 different ways, or several different ways. And I'm going to share those with you. Let's see. I'm on page 18 here if you want to follow along here. We have trouble. We're asked about affordability in sort of 2 different ways. We ask about affordability in terms of, do you not get insurance because do you not buy insurance because it's unaffordable, or why don't you have insurance? The number one reason when we ask people who don't have insurance why they don't have insurance, it's because the cost is too high, right? This is not news to people in this room. But we also ask people about, even if you do have insurance, did you forego care? Did you not go to a primary care clinician? Did you not go to a specialist? Did you not get a prescription drug filled? Or did you not get dental care because the cost was just too high? And what you see here is an aggregation of those measures into the state map. The darker the blue, the more people skipped care. And these are high numbers. This is 25% of the population is saying that they skipped care because of these issues, right? So this is the fundamental task of just about everyone in this room is trying to figure out how we lower not only health insurance premiums, but also care delivery, right? How do we get those costs out of the system in order to do that? Because this is really taking a toll and is very taxing on our everything from general fund to money that you spend out of pocket. So an idea that I'd like you to think about and give me some ideas about where to go. When I thought about this affordability issue, for some reason, Summit County came to mind. And it came to mind for a few reasons. What's one of the reasons that it would come to mind?
Skiing.
Skiing, okay. What about the cost of health insurance premiums? Who knows? Highest. Highest where? Highest in the state? Highest in the country? Right, highest in the country. What else came out about Summit County? In the JAMA. What?
They use more care.
They use more care? How long do they live? They live the longest, right? And so they live longer than anyone else anywhere in the country. And I can't figure out this relationship between how high health insurance premiums are, how high utilization is, and how shockingly high their life expectancy is. So you help me. I need to understand how we can query the CHAS. What's the kind of research we can do to understand the relationship or the correlation between these things?
Don't go see a doctor.
Don't go see. Thank you, Dr. Buckley. I'm going to round this out with a few positive stories. The first one is the story of a very positive checkup for Medicaid. Sometimes we hear a lot about how large the enrollment size is in Medicaid. Sometimes we hear about the taxing that it places or the burden that it places on the general fund, or what's the opportunity cost of spending money on Medicaid and not on higher ed or agriculture or education or K-12 education. But what we don't hear so often is how well it's doing in terms of providing care to its enrollees. And I would encourage you to look at page 17 to look at this in a little bit more detail. We asked people on Medicaid, or we asked everyone actually, about their satisfaction with a number of different health kinds of concerns. We asked about your satisfaction level with the range of services provided. We asked about your satisfaction level with the choice of doctors. And we've asked about satisfaction with co-pays, co-insurance. And these are the ones that relate specifically to Medicaid. We have a few more that we ask about, and you can see those in your book. What's surprising about here is how satisfied Medicaid enrollees are. Nearly 90% of them are satisfied with their range of services, 82% the choice of doctors, and 88%, the 89%, their choice of co-pays. So I think that the people who are involved in Medicaid, the providers in the system, is not only stabilizing and holding its own, but there's some degree of satisfaction with people in there. Who else wants to point out something on this slide? The individual market, yes. And so Medicaid enrollees are happier with their coverage or more satisfied with their coverage than people in the individual market. CHI does quite a few town hall meetings on behalf of legislators. We visit different parts of the state. We often hear a common complaint. And that complaint is, I have to buy health insurance on the exchange. Sure, I get subsidies, but I pay money, and I get a benefit that's not as rich as what you get on Medicaid, right? Has anybody heard that before? All right. You've been to a town hall meeting. And I would suggest to you that this evidence sort of bears that out, right? At least from a satisfaction level, the people who are getting Medicaid are generally more satisfied than the people who are buying off of the individual exchange. I'm not suggesting that a policy option is to make Medicaid worse, but I am thinking about policy options that could help the people on the individual exchange. We saw some legislation introduced last year through the Lieutenant Governor's office to help with subsidies, and so that the burden is not so high for people who sort of fall into that gap as they make too much money to qualify for subsidies, those kinds of things. We might think about a reinsurance pool like they have in Minnesota and Alaska, but I think we might want to think about how we mitigate and improve the experience for people on the individual exchange moving forward. Another idea, or another question that I have for you is, what do we do about this, and what are your ideas? Story number 9. This is where I'm supposed to insert a marijuana joke, but I don't know how to do it, so it hasn't really come to me. Maybe it'll come to me before I give this in Colorado Springs. We are dazed and confused in a lot of ways about our healthcare system, right? And we don't even need marijuana to do this. When we ask people who aren't insured, 1 in 7 don't know how to get health insurance. And so this is the challenge. This is on page 13. They're dazed and confused about how to go about getting health insurance. And I have 3 different categories of how consumers are confused. The first one is around this getting coverage. We have people on the survey respond that they couldn't get coverage because of pre-existing conditions. And we all know, at least in this room, that that was eliminated with the Affordable Care Act. But we still have consumers telling us that they can't get coverage because they have a pre-existing condition. And so I think that begs the question about what we can do differently or better. On page 21, there's also confusion about accessing care. And we ask a question about, did you get preventive care services? And one of the things about the Affordable Care Act, just as a reminder, is that there was something called first dollar coverage. So for prevention, screening, wellness visits, annual checkups, consumers aren't supposed to pay anything with their health benefit package, right? And so we should see a correlating uptick in the use of these services, right? But we actually see that go down this year on the CHAS. And so this went down in a statistically significant way. Only 62% of us are using these preventive services, and that's down from 66% of us in 2015. So again, what are the policy considerations? What are the work and programmatic activities that we should be thinking about in terms of improving that benchmark? The confusion also spilled over into some other questions on the CHAS. And remember, I spent a little bit of time talking about the Medicaid undercount. Well, we think this slide might have something to do with why people who are actually in Medicaid think that they're in a private insurance plan, okay? And so this has nothing to do, just happens to be the system that we have built around getting people insured. If you call Connect for Health Colorado, the first thing that happens to you is that you move over to Colorado Peak. Colorado Peak is the eligibility system, and it screens, the first thing it screens for is your income something that puts you into Medicaid, or is it something that puts you into the exchange market? Then, if you do qualify for Medicaid, you go to something that's now called First Health Colorado, and during the survey, it was called Colorado Medicaid, right? And so there's also we have some rebranding issues going on this year as well. And then when you qualify, you get signed up for a RICO. It could be Colorado Access, or it could be Rocky Mountain. It could be a number of different RICOs. And you might get a letter from Colorado Access, or you might get a letter from your doctor's office, right? The clinic that's actually taking care of you. I am suggesting that this might be a bit confusing to consumers about what exactly do I have, right? I did talk to a few people in the marketing department at HCPF, and they said, my gosh, our logos even look the same. Look at that. It's all blues and greens and happy colors. But at the same time, I think that that can lead to confusion about what exactly do I have. Story number 10 is that Colorado is healthy-ish. So we have lots of people reporting that they're healthy. We have people, let's see, here we go. We have people, this is general health. Over 80% of us say that we are in good, very good, or excellent health. The trick with this number is that all the work that we do in this room, the way that we think about health policy day in and day out, the work that we do on the ground and in the field, we're supposed to be improving this number, right? And what we're seeing is that this number is sort of stubborn. It stays right around that 80% over the last 10 years. So again, how does this correlate to the policy work that we're involved in? How does it correlate to the rules and legislation that we put up? Again, if you look at those four corners, you're also seeing very different stories about just how healthy we are. I think there's probably some correlation here to poverty levels, but that's important to think about, again, in terms of our policy reflections. A bit of sobering news. If you fill up, we don't actually know what to call this anymore. Is it Sports Authority? Is it Mile High? Just say Mile High. So if you fill up Mile High Stadium, it's about 70,000 people. If you take out a few rows, you get to 67,000 people, so it almost fills up the stadium. 67,000 Coloradans are the number of Coloradans who shared with us on the survey that they needed treatment for substance use or for substance abuse and did not get that treatment. It's enough to fill Mile High Stadium. And that's the people who know that they need treatment and know that they need to go get it. It's not the people who don't think that they have a problem. It's not the people who are in treatment right now. It's just the people who know that they need it and haven't been able to get it. Okay? So this, again, where do we see our work in this? And what are the policy implications moving forward? We know a lot of this is alcohol abuse, but we also know that we're dealing with an opioid epidemic. So I am very curious about your thoughts and reflections on that. Finally, you know it's CHI, so we have to be like Spinal Tap. We always got like a number 11. So our 11th, our sort of bonus round for this is a big congratulations to Douglas County. Douglas County has the lowest uninsured rate in the state, and we would submit to you, we would like to put it into a contest for the country. It is at 1.4% are the only people, there's only 4,500 people in Douglas County who don't have health insurance. Yes, I know that it's affluent. Yes, I know it has a high income level. Yes, I know that a lot of people get health insurance through their employers. I know all those things to be true about Douglas County, but this is a testament to that we can do this. We can get to a fully insured sort of state of being. And so it's another sort of point of reflection for all of you here today. So that concludes my 10 sort of opening headlines of the Colorado Health Access Survey. I remind you of these 3 questions. Where should we dive deeper? What policies have contributed to the changes we see? And what do our findings suggest about further policy ideas? I'm going to open it up to questions and comments. These are questions I have. I'm sure you have your own questions. I would like to start with any opportunities for legislators to comment or ask questions. We can always come back to you if you want to take a pass. Yeah?
I'll ask a question. You know, I read this, and first of all, thank you so much for this. It's incredibly interesting information. I'll stand up, maybe I can project here. I'm curious what the data tells us about outcomes per dollar spent, and if there's a way to drill down and let us know more about that subject.
Right.
You know, particularly we don't know what's coming from our friends in Washington, and I'll suspend my skepticism and disbelief for a moment that something actually will come from there in the next few weeks. But let's say that it does, and let's say that it involves some combination of fewer federal dollars and more autonomy, more independence for states.
Right.
obviously one of the challenges for us would be how do we spend those dollars most effectively. So
Right.
anything that this survey, your data tells us about that would be really helpful.
Great. So I think a couple of things. We would probably want to round the CHAS out because this is self-reported data. We have some information on medical bankruptcies. Those are going down quite significantly. We have information on costs out of pocket, and we have information about people who are underinsured, which means they're still paying 10% of their income on medical expenses. And so we could probably round that out with some more information about outcomes. I was asked a similar question yesterday by the Colorado Springs Gazette, and if the Cassidy Graham Heller bill passes, and it changes by the hour whether or not it's going to do that, it will be an enormous challenge to the state, right? Because we will, despite the state opportunities that it affords and innovation that it affords, because there'll be an acceleration of waivers, there'll be some loosening of the kinds of strings that are currently tied to DC, that comes with a finite number of dollars, right? And so the oppositional point of view is like we have to do more with less or innovate with less dollars. Colorado has never seen an innovation that it doesn't like. We are very, very good at using every single lever that's afforded to us, right? And so we've done SIM, we've done Project Echo, we have done Evidence Now. We have, you know, when the buffet of policy levers has been offered to us, we take them up. We've expanded Medicaid. We tried our hand at the Colorado Health Op. Didn't work out so great for us. But, you know, the idea is that we're very, very good at trying those things on. And I have a lot of optimism that we as a community will continue to do that. Anything else? Yeah, Senator.
So I would love more information about wait times for primary care and specialty care, divided up between Medicaid and private insurance, especially in some of the underserved or underinsured areas.
Right.
To get some sense of where we're having trouble with our Medicaid patients. And also how you correlate the 72.5% who said they couldn't get an appointment for a general doctor when they needed one with data that suggests we have enough primary care providers in our state, and what the disconnect is there.
Right. We have those Medicaid numbers. The picture for Medicaid in general is not as rosy as it is for the state average. You wait longer when you're in Medicaid, but we'll follow up and give you the detail around that. And the wait time question was an interesting one because it had sort of an odd distribution. There were people who told us that they waited a year and a month to get to a specialist visit, right? And so, that was bad voodoo when that happened before. Okay. You know, and so we have these outliers on that question that we don't see on other questions, and so it's not to negate that. We chose to share the median rather than the mean on that question because of this sort of odd distribution pattern, but we can certainly dive into that a little bit more. Yeah, Dr. Clark.
Michelle, just tagging on to Irene's comment, can you break specialty care down into the various specialties? Maybe you've already done that. There's a big difference between finding a pediatric surgeon to take care of you and finding an orthopedic surgeon. We've got so many orthopedic surgeons.
Right. I don't think we can do that on this survey. We have done some work externally to this survey that incorporates some of this to get to that answer, but we can share that with you offline. Yeah.
So as well, kind of on that, I was curious if you guys have all, I mean, you did see that drop in preventive care.
Right.
Have you actually broken down wait times, broken down the wait times in terms of preventive care visits versus acute care visits? Just anecdotally, I know that a lot of times you see a huge difference. If you're going for an acute care visit, it is 1 or 2 days.
Right.
If you're going for a preventive care visit, you're looking at weeks and months. And so that might actually be something very interesting to look at.
Right.
You're seeing that drop in preventive care.
Yeah. We can follow up with that. Deb, are you making a note? Okay, but I don't think that we get to that level of detail. It's a self-reported survey, and so when you're asking sort of your general Coloradan whether or not it was acute or preventive, it gets a little probably dicey. And so, but we can certainly follow up on that. Yeah.
Going with the same idea of wait time and access to care issues, I don't know if you have the numbers to actually stratify the Medicaid versus private insurance wait times by HSR, but it would be really interesting to compare a lot of the different pieces about, is it that wait times are longer for Medicaid enrollees in certain parts of the state versus other parts of the state, and what can we do about that? And
Right.
how does that correlate with other pieces of data from the survey?
Great. I like that suggestion. Thank you very much. Yeah. Jeannie.
In a previous report, you compared the uninsured with the underinsured.
Right.
And we saw an encouraging trend in a decrease in the uninsured, like we were seeing today. But what is the trend for the underinsured, and how do you define underinsured?
Right. So I think that we don't have it today, but we can certainly, that's something that we can look into. We typically define underinsurance, with the few exceptions, as households who are spending more than 10% of their income on medical care, regardless of whether or not they have health insurance. It's a hard number to calibrate, and so we need to do a little bit more research back at the ranch in order to have that data for you, but it's something that we can certainly take a look at.
And Michelle,
Yeah.
Page 19 does have out-of-pocket spending.
Okay.
So that does have some information.
Okay, gets you close, page 19. Dee Dee. Just shout. Yeah.
What are the strategies you use to ensure that you're getting information, representative information from recent immigrants, refugees, and undocumented?
Right. So I will point to you. Can you Can you get to the point, Deb, of the citizenship question? 16. So, Dee Dee, we get a lot of questions asking about people without documentation status. Of the 350,000 people that don't have health insurance, we estimate from other data sources that 25% of that population are people without documentation. For reasons of our IRB, for legal reasons, for HIPAA reasons, and privacy reasons, we don't ask about documentation status. And so we can't directly answer that question, but we can take a look at the reasons that people are uninsured and sort of extrapolate from that what might be the biggest causes, because that's the population here in Colorado that is really untouched by the Affordable Care Act in any meaningful way. So we can get you close to that. We could shed some light on it without definitively answering your question. Yeah, Senator Lontine.
I had a question around the emergency department use.
Uh-huh.
And you have in the synopsis at the top that 36.5% of Medicaid enrollees are using the ED, which is more than the uninsured population.
Right.
So is there any correlation between that and the fact that it's harder to get in to see a doctor? And then you have an 8.6% increase in convenience as a reason.
Right.
In what category was that more likely to be a Medicaid population or
right.
Private insurance, or how did you have any kind of categorization with that?
So it is true. We're looking at page 24 for those of you who are interested in this. That we do see higher use of emergency department services from Medicaid. I don't think that we've cut the data looking at this question of 8.6% increase in convenience, but it's something that we can certainly get back to you on. It's a it could be a really rich analysis and discussion. Yeah,
For
Carrie.
Summit County, I'm kind of curious as to
Wake up! Yeah, it's time to wake up. Yeah.
Just curious whether you're looking at non-Colorado residents receiving care and their impact Summit County is a vortex of skiing and excitement, and I live in Kansas, and I get an injury and
Right.
I receive care. Is that impacting our state?
Right. It could be impacting overall utilization. It could be impacting the cost structure of those facilities up there. I would think that it would impact them in a pretty positive way. When we look at the insurance premiums that I highlighted, those are what it costs if you're buying in Summit County, right? And so I don't think it's reflected in those numbers. But you do have a lot of people who are snowbirding in, or whatever you call that, when they come into their second homes. So good point. So, yeah, Bibi.
I know on the individual market, people are buying bronze level plans or silver plans. Does that impact access? We're seeing that if you buy a bronze level plan, you're not going for care because your
Right.
out-of-pocket is so high. So it's like having no insurance.
Right. So Bibi makes a really astute comment, and that is, what's the relationship between these high deductible plans and the decrease in preventive care? And she's seeing through her work at Doctors Care that there's a correlation between these two things. If I have to start paying for these things, I'm going to think twice about that rather than having them covered. So part of the issue might be an education issue. People don't know that their annual well check and their mammography screens and their flu shots and things like that are covered, right? And so there's first dollar coverage on those. We've learned from our conversations with Commissioner Salazar, there can be what is perceived as sort of a bait and switch. You go in for one thing, the minute you start talking about your genetic history or your asthma, then it gets recoded as to something else. And people are increasingly aware of that, or at least cautious about going and using those preventive services. So all sorts of issues, legislation, regulation, policies that can be sort of teased out of that, but I think that's an important point. So, yeah, Catherine.
Going back to, and maybe building off of some of Senator Nicholson's comments, it would be really interesting to dig a little deeper in some of the cost correlations regionally. So, right, like 78% of folks cite cost as a reason to not buy insurance. And in a good way, fewer people are struggling to pay their medical bills, right? We're down to 14%. Right. But it's interesting to look at how those regions correlate or don't correlate, particularly to the decision to skip care because of cost.
Right.
And kind of looking into that behavior by insurance type.
Okay. Duly noted. Thank you. Who sees their work in the results? I'm interested in that. Share a reflection with me. Sure. Yeah.
Dental Association on the oral health statistics, I definitely see, and thanks to Senator Nicholson and many others in the room, but in 2013 we added an adult Medicaid benefit, and I think you definitely see that reflected in the coverage as well as the utilization of services.
All right. So kudos to the people on the oral health benefit. Who else sees their work in these results? Yeah.
So I live in Arapahoe County, work there, and so we've decided to move forward from just getting people enrolled to health insurance literacy, right? That's our next frontier. So we see our next frontier in these results.
Yes. Okay. So tackling this issue of the dazed and confused through literacy and outreach. Great. Any other questions or comments? Yeah.
So at the State Health Department, we really are looking at health equity as a priority we have for years, and also structural inequities that lead to these disparities. And it'd be interesting, we're talking about how do we dive deeper into sometimes those other categories, the subpopulations, especially in our state of Native Americans, African Americans, other populations that typically have larger health inequities, especially compared to national data.
Okay, hold on a minute.
Yeah.
I turned my lav off, so it's not me. So, just for the record. Okay. Katja, start over again.
We're already being the idea that if we can dig into more more subpopulation data, whether we have to extrapolate our data with national data from Indian Health Services or other populations, or we have to combine years of data so that we can get to more subpopulation data and look at their inequities with more of a lens of how do we help the populations that have the most disparities, and then look at all the different metrics with those different breakouts. And then also how do we prepare for the changing demographics of Colorado as we know that we are going to become, a state with more people of color and also older people. So how do we deal with that and plan for that with by digging into the data more?
Right. So Katya's question gets to this idea of how do we get more granular? How do we look at things by subpopulations? How do we look at them in more detail and at a more local geographic level? And the CHAS, even though it's 10,000 households, has some constraints in terms of how granular you can get. You sort of slice and dicing, and your sample size gets squishy. That's the technical term that the statisticians use with me. But there are some new methods that we have employed at CHI and will do again this year, where you take information that you do have at a really granular level and you combine it in some pretty sophisticated ways with what you have at the regional level, and you're able to create some estimates of health outcomes, barriers to care, and insurance coverage. And so we will be looking to do that in the next 18 months or so. Great. Yeah, Michelle.
So rural communities fare worse in all of these categories.
Yes.
So I would love if maybe we could work together and dig into some of this and create a rural-specific report that we might be able to come out with some specific policy changes that would be able to assist rural communities.
Great. Love to do that. Anything else? All right. Thank you so much for your time. Thanks for being here today. March out with the CHAS proudly and come to CHI and ask us for any questions or any further analyses you'd like us to do. Thanks so much. Enjoy the day.